liver resection for colorectal liver metastases. I'm currently in Poissy, which is in West Paris. Let's see here, there we go. I have my academic appointment at the University of Magdeburg in Germany. I have some disclosures. I'm a consultant for Moon Surgical, which we'll see a little bit later. I'm also the editor-in-chief of Artificial Intelligence Surgery. So the objectives, we're going to discuss the Similar 1 and Similar 2 trials. We're going to discuss the difference between robotic liver surgery with a complete robotic system versus handheld robotics. Liver resection is done with handheld robotics. And we're also going to define what non-console complete robotic systems are. The concept of robotic surgery is in constant evolution, and that's why I want to touch upon that a little bit. So this is the study. It was published in Cancers. We were actually invited to guest edit a special issue, and this is one of the papers that we published there. Initially we called Similar 1, Similar CRLM for colorectal liver metastases, and it was initially from 6 centers. When we went through the criteria, only 5 of the international centers ultimately met criteria and were able to participate in the retrospective review. We had 2 centers in the United States, a center in Taiwan, a center in Italy, and I believe a center in France. So resections were divided by the approach used, either open liver resection, laparoscopic liver resection, or robotic liver resection. We followed the Milan criteria. The Milan criteria are no longer only used for hepatocellular carcinoma. You can also use it for colorectal liver metastases. So just to review, the Milan criteria are patients without macrovascular invasion, if they have greater than 3 metastases. So these are people that are outside of my Milan criteria. Patients with macrovascular invasion, more than 3 metastases measuring more than 3 centimeters, or solitary metastases measuring more than 5 centimeters. So we used less than 5 centimeters, 3 or fewer metastases, and no macrovascular invasion. Okay? Furthermore, remaining heterogeneity that was found was further analyzed, and we did propensity score matching to decrease any potential bias. So I'm reminded from my high school history class during World War I, the Germans had this term, Zweifrontenkrieg. I apologize for my accent, but it's war on 2 fronts, right? And as a laparoscopic surgeon, a laparoscopic liver surgeon, I found myself a little bit understanding this word more, because not only am I battling with the open surgeons, but I'm also now battling with the robotic surgeons. And with a little bit of time, your perspective on a problem changes. So hopefully you'll see what I mean by that as we talk through this. Initially, prior to matching, we had 566 patients in the open group, 462 in the laparoscopic group, and only 36 in the robotic group. Nonetheless, we didn't want to just compare open and laparoscopic, or laparoscopic and robotic. We really wanted to compare all 3 in one paper, because it's much more interesting to us, because the modern day liver surgeon really can't afford to just do 1 or even just 2 of these. I think you really need to be facile with all 3 to give the best benefits to your patients. So this just, does anybody have a pointer? Or maybe I can use my arrow. No, oh, can you see my arrow? No. Do you guys have a pointer? A pointer? Yeah, maybe not. No, okay. So, hopefully you can see here, but this is before matching. You can see in the open group, in the first column, the ASA is worse. You have sicker patients in the open group, which can be expected. You can also see more previous surgery in the open group, more chemotherapy in the open group, the larger metastases, more metastases. So before we did propensity score matching, the study was essentially useless, especially when you compare lap and robotic versus open. So after propensity matching, however, all of these differences went away. As you can see, in the blue, you have open liver resection. In the green, you have laparoscopic liver resection from 2004 to 2020 in all centers. And in the yellow, you can start to see that robotic surgeries are making inroads. So this is just showing the shifting tendencies of the different approaches for liver surgery. Robotic surgery is essentially becoming more prevalent, and laparoscopic surgery is also more prevalent. And the bottom line is open liver surgery is being done less and less in kind of larger centers that do liver surgery. It doesn't mean to say that open surgery is going away, it's just saying that more minimally invasive surgery is being done. So this is just comparing open and laparoscopic. Again, before matching, you have 375 and 378 in the two groups. After matching, you have 142 in each group. And after matching, this is just to show you that before surgery, there are no differences. However, after surgery, which we can't control after surgery, we didn't want to control this. We just wanted to control the preoperative criteria. But you can see in the laparoscopic group, we have less blood loss, not a surprise. Hospital stay is decreased, and there are fewer complications in the laparoscopic group when you can do it to open. So we have some short-term benefits. Okay. So what about when we do open and robotic? Again, before matching, we had 375 compared to just 28. After matching, we only had 22 in each group. Nonetheless, we wanted to see what we could find. And after surgery, we found that blood loss was actually decreased in the robotic group. But you can also see that we did, actually no, I'm not gonna, that's it. So basically, in the robotic group, we had decreased bleeding, okay? Now, when we compared laparoscopic and robotic, you can see here that we have estimated blood loss is lower in the robotic group, again, as compared to the last slide, and that's really the only change, okay? There you go. So the results of the propensity score matching, again, just to review, there are 142 in each group in the open and the laparoscopic, but only 22 when we added the robotic groups. So blood loss, hospital stay, and morbidity rates were all highly statistically significantly increased in the open when compared to the laparoscopic group. As you can see, 600 compared to about 350 milliliters, or 9 days versus 5, and morbidity rates were 25 in the open group compared to about 6% of the laparoscopic group, all highly significantly decreased in the laparoscopic group. In the robotic group, only blood loss was significantly decreased when robotic was compared to open and laparoscopic, okay? So in the open group, it was 597 in the open group compared to 250 in the robotic group, and in the laparoscopic, it was 778 compared to 224 in the robotic group. So conclusions of SIMLR 1 trial was that it's just short-term findings indicates that minimally invasive approaches to colorectal liver metastases that follow the Milan criteria may have short-term advantages. We wanted to do larger studies with longer-term follow-up. The robotic groups are still needed, but what we wanted to present in our first paper was the follow-up, was the survival. The editors didn't like that, so we decided not to fight them, and we decided to come out with a second paper. Hence why we called it SIMLR 2, looking at the oncological factors, and this is what we're going to present now. So when you look here, this just shows that we looked at which patients had synchronous liver metastases. You would think that they would have worse outcomes than people who present with metachronous liver metastases, presenting later on after maybe having a colon surgery, maybe a year, maybe 6 months later. You would think they would have a better survival, and we know that. So when we look at that, in the open group, people tended to have fewer synchronous lesions than the laparoscopic group. And in the open to robotic, again, there was really no change. And what this slide is trying to show us is that after matching, there were no statistically significant changes or differences in patients with synchronous lesions, patients that got neoadjuvant chemotherapy, the type of chemotherapy, and the type of immunotherapy that they got, the biologicals that they got. So I know it's a busy slide, and I can't really go through it. Oh, I have it. We're in luck. Thank you so much. This is going to help a lot. Is that it? No. Oh, this is still not a pointer? Or it is? Ah, there it is. It's a small red dot. Wow, okay. Yeah, it works on the blue, but it doesn't really work on the white. So, the bottom line is, if I could show you on the top line, the synchronous lesions are more in the laparoscopic group. They're tending to be, but they're not statistically significant. So we'll just skip this slide. Just lo and behold, there were no statistically significant differences in either the open laparoscopic or robotic group. There were some tendencies to be significant, but it didn't attain statistical significance, okay? So I just wanted to mix the robotic and the laparoscopic group together to see. This was kind of just out of curiosity. And you can see synchronous lesions tend to be more, actually this was significant on the first line in the minimally invasive group. When you look at it as a whole, interestingly, there were more synchronous lesions in the laparoscopic or robotic group, which makes sense because people would do a colon resection and a liver resection at the same time, minimally invasively. Maybe they didn't want to do it at open surgery. Okay? Neoadjuvant chemotherapy, there were no differences. About 70% of patients got neoadjuvant chemotherapy. Equal amounts got either FOLFOX or FOLFIRINOX or 5-FU alone. As far as neoadjuvant biologicals, people got bevacizumab about a quarter of the time, or cetuximab about 12 to 13% of the time in both groups, okay? This is an open and minimally invasive. So finally, the Kaplan-Meier survival curves. When we look at open and laparoscopic, overall survival was in around the 35% range, whether you do it open and laparoscopic. So I've been talking now for about 12 minutes just to show you that as far as survival is, when you compare open to laparoscopic, the results are similar, okay? You have short-term benefits, of course, but at the end of the day, the most important thing is survival, and they're similar, which is great for laparoscopic surgeons because it tells us that you can approach tumors laparoscopically and you can have the same survival whether you do it open or laparoscopic. As far as recurrence-free survival, they're also similar. No statistical differences whether you do it open or laparoscopic for colorectal metastases that meet the Milan criteria. The reason we use Milan criteria is that's what we do whether we do it open or laparoscopic, but also this is the best way we can compare honestly open and laparoscopic. Because when we didn't do that, before propensity score matching, when we just looked at all tumors, there was a huge bias. I know I'm biased. When I have a big tumor, I do it open. When I have a smaller tumor, I want to do it laparoscopic. So again, I try to eliminate it by just doing the Milan criteria and then doing propensity score matching. The only way to truly know the answer is with a randomized controlled prospective study. But nonetheless, this is the best we can do now to give a little window into the future. So what about when we compare open and robotic? We don't really have enough data. This is just to show you that there's no statistical significance in overall survival. Recurrence-free survival. What happened?
تمشي جوهرة
Overall survival, open and robotic, similar. Recurrence-free survival, open and robotic, similar. When we look at laparoscopic and robotic, again, we don't see a difference. We don't have enough patients yet. But the important thing is to see and to show that in the beginning, what we're seeing is really there's no difference. There's no advantage to laparoscopic or robotic or open as far as survival is concerned, okay? So results of overall survival at 5 years, it's about 35% after open, about 37% after laparoscopic, no difference. Again, going through open and robotic, you have 34 and 47%, no statistical significance, and 30 and 47%, but again, no statistical significance. Recurrence-free survival, you're finding the same thing. It's about ranges between 12 and 20, open laparoscopic, 33 and 26, open and robotic, 22 and 34, comparing laparoscopic and robotic. So conclusions, when comparing all three different approaches, overall survival and recurrence-free survival were similar after utilization of the Milan criteria and propensity score matching. Biological agents tend to be utilized more in the open group when compared to the laparoscopic group, suggesting that highly aggressive tumors are still managed through an open approach. So I'm probably over, but I'm going to try to squeeze this in anyway. I wanted to look at what happens when we use handheld robotics. Okay, this is comparing now handheld robotics to complete robotic systems, the Da Vinci. So what I'm just going to go right to the end. What is handheld robotics? You can use robots that fit right onto the patient. You can have staplers that have artificial intelligence in them with sensors. You can have robotically controlled instruments that you can hold in your hands. Oh my God, no fair. Can I have 30 seconds? Do I have to hit this? How do I cheat? I guess not. Hello? I'm back. Okay. So we'll skip this video. Don't worry. So this is just showing 4 international centers comparing complete robotic systems to handheld robotics. And I'm just going to show you that the only thing I wanted to show you here is when you use handheld robotics, that about 90% of your surgeries can be done minimally invasively. When you use the complete system, only about 34% of your patients are done robotically. So there are some advantages. People should look into handheld robotics. I'm just going to skip right to this. There are also non-console robotic systems coming on the market where the surgeon maintains contact with the patient. The systems are much cheaper than the Da Vinci. I encourage smaller hospitals and bigger hospitals that want more access to robotics to consider these systems. I am a consultant for Moon Surgical. I'm not an owner. I just recommend that you look into this technology because it's going to be a lot better, I think, for health in general. A Lancet article in 2015 showed that 60% of the world has no access to healthcare or surgeons in particular. So this is a great way for more people to benefit for robotics. So I'm just going to skip and thank you.